Did you know that nearly 1 in 3 adults worldwide has high blood pressure? And most of them don't even know it. It's called the silent killer because it slowly damages your heart, kidneys, and brain without any warning signs. In this video, we're breaking down everything you need to know about hypertension and the drugs used to treat it, the definitions, the types, the causes, and every single class of antihypertensive medication, explained simply. Stay till the end, because we'll also give you a quick revision summary. Let's get into it. Let's start with the basics. Hypertension simply means persistently high blood pressure in the arteries. According to current guidelines, a person is considered hypertensive when their systolic pressure, the top number, is 130 millimeters of mercury or higher, or their diastolic pressure, the bottom number, is 80 or higher. Think of your blood vessels like garden hoses. Normally, water flows through at a safe, steady pressure. But in hypertension, that pressure inside the hose stays too high for too long, and over time, it damages the walls of the hose, which in your body means damage to your arteries and organs. Blood pressure is classified into categories. Normal is below 120 over 80. Elevated is 120 to 129, with diastolic still under 80. Stage 1 hypertension is 130 to 139 over 80 to 89. Stage 2 is 140 or higher over 90 or higher. And anything above 180 over 120 is considered a hypertensive crisis, which needs immediate medical attention. Now, there are two major types of hypertension. The first is primary, also called essential hypertension. This has no single identifiable cause. It develops from a mix of genetics, lifestyle, and environment. And it makes up about 90 to 95% of all cases. The second type is secondary hypertension, which happens because of an underlying condition. Things like kidney disease, hormonal disorders such as Cushing syndrome or pheochromocytoma, certain medications like NSAIDs or oral contraceptives, or pregnancy-related conditions like preeclampsia. This only accounts for about 5 to 10% of cases, but it's important because treating the underlying cause can actually cure the hypertension. There are also a few special types worth knowing. Isolated systolic hypertension, common in the elderly due to stiff arteries. Malignant hypertension, a sudden dangerous spike that damages organs immediately. White coat hypertension, where blood pressure rises only at the doctor's office. And masked hypertension, the opposite. Normal at the clinic, but high at home. So what causes hypertension? Some risk factors we cannot change, like age, family history, race, and gender. But many are modifiable, meaning we have control over them. These include obesity, high salt intake, a sedentary lifestyle, smoking, alcohol, chronic stress, diabetes, high cholesterol, and even too much caffeine. Here's an easy way to remember the modifiable ones. Think of the word salt, sodium excess, alcohol and smoking, lifestyle inactivity, and tension, meaning stress. These are the everyday factors we can actually work on. Now let's move to the most important part of this video, the drugs. Antihypertensive medications are divided into 7 major classes. Diuretics, Sympatholytics, which include centrally acting agents, alpha blockers, and beta blockers. ACE inhibitors, Angiotensin receptor blockers, or ARBs, calcium channel blockers, direct vasodilators, and direct renin inhibitors. Let's go through each one at a time. First up, diuretics. These drugs work on the kidney to remove excess sodium and water from the body, which lowers blood volume and, in turn, lowers blood pressure. There are 3 types. Thiazide diuretics, like hydrochlorothiazide, block sodium and chloride reabsorption in the distal tubule of the kidney. They're usually dosed at 12.5 to 25 milligrams once a day. Watch out for side effects like low potassium, high blood sugar, and high uric acid, which can trigger gout. They also interact badly with digoxin because low potassium increases digoxin toxicity, and with lithium because they reduce its clearance from the body. Next, loop diuretics, like furosemide, act on the loop of Henle and cause much stronger diuresis. They're commonly used in patients with kidney problems or heart failure. Watch for low potassium, low magnesium, and importantly, ototoxicity, damage to hearing, especially when combined with aminoglycoside antibiotics. Finally, potassium-sparing diuretics like spironolactone block the hormone aldosterone, which means the body loses sodium but keeps potassium. Because of this, they can cause dangerous hyperkalemia, especially if combined with ACE inhibitors or ARBs. Spironolactone can also cause gynecomastia in men due to its hormonal effects. Next, we have sympatholytics, or drugs that reduce the activity of the sympathetic nervous system. There are 3 subtypes here as well. First, centrally acting alpha-2 agonists like clonidine and methyldopa. These act in the brain to reduce sympathetic outflow to the blood vessels and heart. Methyldopa is actually the preferred choice during pregnancy. But be careful. Stopping clonidine suddenly can cause a dangerous rebound spike in blood pressure. Second, alpha-1 blockers like prazosin, which relax blood vessels by blocking alpha-1 receptors. The biggest concern here is the first dose phenomenon, a sudden drop in blood pressure after the very first dose, so it's usually started at bedtime in a low dose. Third, beta blockers like atenolol and metoprolol. These reduce heart rate and the heart's workload and also reduce renin release from the kidneys. Side effects include bradycardia, fatigue, and importantly, they can mask the symptoms of low blood sugar in diabetic patients. Non-selective beta blockers like propranolol should be avoided in patients with asthma because they can trigger bronchospasm. Now, ACE inhibitors, drugs like enalapril, ramipril, and lisinopril. These block the angiotensin converting enzyme, preventing the conversion of angiotensin 1 to angiotensin 2. Less angiotensin 2 means less vasoconstriction and less aldosterone release. The signature side effect here, and this is a favorite exam question, is a dry, persistent cough. This happens because ACE inhibitors also block the breakdown of a substance called bradykinin, which builds up and irritates the airway. Other risks include high potassium and a rare but dangerous swelling reaction called angioedema. These drugs must never be used in pregnancy because they are teratogenic, and combining them with potassium-sparing diuretics or NSAIDs increases the risk of complications. Next, angiotensin receptor blockers, or ARBs drugs, like losartan, valsartan, and telmisartan. Instead of blocking the formation of angiotensin 2 like ACE inhibitors do, these drugs block its receptor directly. Because bradykinin isn't affected, the dry cough seen with ACE inhibitors is much less common with ARBs. Just remember this simple rule. ACE inhibitors cause cough, ARBs generally do not. Both classes still carry the risk of high potassium and are contraindicated in pregnancy. Now, calcium channel blockers, which come in 2 main types. The dihydropyridines, like amlodipine and nifedipine, mainly act on blood vessels, causing them to relax and widen. Common side effects include ankle swelling, flushing, and headache. The non-dihydropyridines, like verapamil and diltiazem, act on both the blood vessels and the heart itself, slowing the heart rate. Because of this, they can cause bradycardia and severe heart block, especially if combined with beta blockers. Verapamil is also well known for causing constipation. And here's a fun fact for your patients: grapefruit juice can significantly increase the blood levels of these drugs, so it should be avoided. Next, direct vasodilators drugs like hydralazine and minoxidil. These act directly on the smooth muscle of arterioles to relax them. Hydralazine's unique side effect is a lupus-like syndrome joint pain and a rash resembling lupus. Minoxidil, on the other hand, causes hypertrichosis, meaning excess hair growth, which is actually why it's used in topical form for hair loss treatment. Both drugs commonly cause reflex tachycardia, so they're often combined with a beta blocker to counteract that fast heart rate. Finally, we have direct renin inhibitors, with aliskiren being the main example. This drug blocks renin itself, the very first step of the entire pathway that leads to angiotensin 2 formation. Its most common side effect is diarrhea. And just like ACE inhibitors and ARBs, it should not be combined with them, because studies have shown this combination significantly increases the risk of kidney problems and high potassium. Alright, let's do a rapid-fire recap before we wrap up. Thiazide diuretics, low potassium and high blood sugar. Loop diuretics, ototoxicity. Potassium-sparing diuretics, high potassium and gynecomastia. Central alpha-2 agonists, rebound hypertension. Alpha-1 blockers, first-dose hypotension. Beta blockers, bradycardia and masked hypoglycemia. ACE inhibitors, dry cough. ARBs, same benefits, no cough. Dihydropyridine calcium channel blockers, ankle edema. Non-dihydropyridine calcium channel blockers, bradycardia and constipation. Vasodilators, lupus-like syndrome or excess hair growth. And renin inhibitors, diarrhea. That's your complete rapid revision of antihypertensive drugs. And that's a wrap on antihypertensive drugs. From definitions and causes, all the way through every major drug class. If this helped you understand the topic better, hit that like button, subscribe for more pharmacology content, and drop a comment if you want us to cover the next topic. Thanks for watching, and we'll see you in the next one.